It is in some states, so it depends on the state that you're in. Right. Last I checked, I haven't recently checked that law, but last I checked, that was the law. No, a CVS can. It looks at chromosomal cells. Yeah. They both, amniocentesis and CVS, can look at the chromosomes of the fetus to determine if there is a chromosomal anomaly, like that's going on. So like Down syndrome or trisomy 18, there's a bunch of different trisomies that some of them are incompatible with life. And so they could choose, if it's legal in that state, to abort. Absolutely. Mm-hmm. Yep. Yes, you could. All right. You ready to learn about labor? Move on to intrapartum. I'm going to go ahead and share my screen. Right. So labor process and nursing care. We'll go through these slides here. The definition of true labor is the process of moving the fetus, the placenta, and the membranes out of the uterus. So that whole, all of those parts are the pregnancy. Okay, so moving all of those parts out of the uterus is labor. Labor begins with regular uterine contractions, and it continues through cervical dilation and birth, and it ends with the patient and the family beginning the attachment process or the bonding process. When we think about labor, we think about the 4 P's of labor. There's actually 5 P's. Your textbook goes with 4, but I like to tell you the 5th one because that one becomes super important too. So our ultimate goal in labor is to have a vaginal birth, right? Because that's what's safest for mama and baby. And so we're going to do all of these things to make sure that all of these 4 P's work together, which will give us our desired outcome of a vaginal birth. The first P, which we'll break these down in just a minute, is passageway. That's referring to the birth canal or the vagina. The next P is passenger, referring to our fetus. There are many different things we look at in relationship to the fetus. The other P is powers. Power is referring to the uterine contractions, how strong they are. And also, once we get to 10 centimeters dilated, pushing with contractions. So powers, how strong are the contractions and how good is the maternal pushing once we start pushing with contractions. And the other P is psyche. How is mama dealing with that pain? Or dealing with the process of labor. Is she comfortable with everybody that's in their room or in her room? If she's not, we're all mammals, right? And so mammals like to be comfortable in their environment. Some may even go and hide away from everybody in birth. And so as long as, if mama is not comfortable with the people that are in her room, she's not going to labor well. Okay. Also, how does she deal with the pain of labor? Pain in labor is totally normal and expected. And so how is she dealing with that pain? What's her plan? Does she want pain medicine? Does she not? And that's totally fine if she doesn't. We'll do lots of different things to help support her if she doesn't. There are different types of pain medicine, which we'll talk about in the next slides or slide deck. Different types of things that we can do to help manage her pain. The fifth P is position. Getting mama into many different positions throughout labor, trying what's comfortable for her and what works for her, getting her to open up that pelvis and move around will help that baby rotate the passenger, right? Rotate into the right position that's optimal for a vaginal birth. So being laboring in the bed is not optimal for a vaginal birth because we're not changing different positions and getting that baby to rotate as it should. Unless we have an epidural, we really want her to be out of the bed and doing different positions. Starting with the first P, the passageway, that's where our pelvis starts to come into play, okay? Not only the pelvis, but the cervix and the vagina, the birth canal. When we're thinking about the pelvis, and I forgot my pelvis. I left it at school today in lab. I will show you guys the pelvis when you're in lab this week. We're looking at, do we have the optimal shape, right? Remember in the repro lecture, we learned about false pelvis, which is the hip bones, versus the true pelvis, which is that hole in the middle of the pelvis. The pelvic inlet is where the baby would descend in, and the pelvic outlet is when the baby comes out through the pelvis, okay? We're also looking at these little tiny bony prominences, which is on the underside of the pelvis. We're not looking at it, we're actually feeling for it when we do a vaginal exam. When we do a vaginal exam, we insert 2 fingers, palm side up, and we can measure how far dilated or open the cervix is and how thick it is. And then we're also feeling where that baby's sitting at in relation to those spines. And we'll break that down even farther in a future slide here. The gynecoid pelvis, this round-shaped pelvis, GYN, like our OB-GYN, right, is the most optimal shaped pelvis for birth, okay? Any of these other ones, it's not likely that that baby's going to be able to fit through, okay? Don't worry too much about this, but when the provider or when the patient is seen in the provider's office, the provider is going to do a measurement called an obstetric conjugate. What they do is they do a vaginal exam, so insert their fingers, they feel the patient's spine, and then they measure how far up the suprapubic bone comes into contact with their fingers. It's measured in centimeters, and we learn about how much centimeters feels just by practice and checking cervixes and this obstetric conjugate. And so if it's greater or about 10.5 centimeters, that means that that baby will probably fit through her pelvis once it's time. When we talk about the soft tissues and not the pelvic structures, we're thinking about the cervix. How far open is it? That's dilation. And how thick is it? That's effacement of the cervix. And how quickly is it dilating? Is it dilating like a normal cervix would, which is about every 1 centimeter every 1 to 2 hours for a first-time mom? Or is it dilating much slower than a normal cervix would? Full dilation of the cervix is equal to 10 centimeters, which typically for me on my little fingers here is with my fingers all the way stretched out. But also 10 centimeters means there's no more cervix surrounding that fetal head. Okay, so really no more cervix is able to be felt. And then the vaginal tissue as well. Oh, look at Marlena has a nice dilation chart there, which we also will have in the lab, so you guys can get to feel for what that feels like with your fingers. Marlena. For our passenger, that's our baby, right? Our fetus. There are many things that come into play as far as if we could have a vaginal birth. Okay, the fetal skull is the largest and least compressible part. As the fetus goes through the birth canal, these bones in the skull are not fused together. So they will start to mold or cone as the baby is going down through the passageway, right? The birth canal or the into the pelvis. It'll mold into a cone shape so that the baby's head can fit better through there. And so if the patient is a first-time mom, that molding might be more prominent in some newborns than others, okay? If she's had more babies, it might be less molded because all that tissue has been stretched before. Now, when the baby's born, that molding will still be there for up to 24 hours-ish after birth, and that's normal. The baby's head will start to form back into its nice round shape. Some first-time parents aren't aware that this happens, and so they kind of freak out when they see this big old cone head on their baby. Usually we'll just explain, hey, that's just so a baby could fit through the pelvis, and don't worry, that shape will return to normal very shortly. Then we throw a hat on it and they forget all about it because they can't see it. We're also looking at how is that baby lying in relationship to mama's pelvis, okay? The longitudinal lie would be straight up and down, whether the baby's head first or butt first. Any longitudinal lie is likely that you could have a vaginal birth, okay? Is the baby laying crosswise or oblique? That would be very difficult to birth. You actually cannot birth in an oblique position. And also transverse, babies lying sideways in the abdomen, that also cannot be birthed vaginally. Okay, so any longitudinal lie, cephalic or vertex, that it can be birthed vaginally. There are three main fetal presentations. So remember, fetal presentation means what is the presenting part? What's the first part that's going to come out during birth, okay? If the baby is head down, that's called cephalic or vertex position. The head is presenting first. This is our optimal position for birth because that head can mold as it goes down through the birth canal. A breech position means that the feet or the buttocks are presenting first, like this image here. You can have different types of breech. Frank breech is where they have their legs straight up over their head, okay? Sometimes when they have this frank breech and they're born, even via a C-section, their legs are so used to being up, they'll just go up for a few hours after birth because they're just so used to being up there, okay? Then they'll start to settle down. Complete breech, they're in the fetal position, but their tush is presenting first. You have a single footling breech where one foot is presenting first and the other is curled up, or a double footling breech where both feet are presenting first. They're really still curled up in the abdomen, but both feet are coming first instead of the tush, okay? In frake or complete, if the obstetrician or the provider is trained and comfortable with delivering a breech baby, typically they will. But most of the time nowadays, it is high risk to deliver a breech baby because that head doesn't get the molding that it's supposed to because it's not presenting first, right? And so sometimes the head can get stuck at birth. So a lot of providers will just choose to do a C-section instead if they can't get the baby to turn. Single footling and double footling, if the water breaks, there's a high risk of the cord coming through the cervix and pinching off. It's called a prolapsed cord. I don't know if we talked about that last class or not. Prolapsed cord would come through the cervix, sometimes even out of the vagina, and it clamps that cord, and baby doesn't get any oxygen from the placenta. And so that's an emergency if that happens. If we can't get that baby to turn, they likely won't labor that patient at all, because as the cervix opens, we have the risk of that foot coming through and the cord coming through. So typically they'll just do a scheduled C-section for these two footlings. Okay. Also, less common is the shoulder. So if baby's transverse in the abdomen or oblique and the shoulder is presenting first, that can definitely not be born vaginally. It won't fit. Okay, so that does have to be a C-section if we can't get that baby to turn. As I said a couple times, if we can't get the baby to turn, we would do water therapy, get them in the pool, maybe the tub. Sometimes that gets the baby to flip on its own. You could do chiropractic treatments to try to get the baby to turn on its own. Or the provider might offer to do an external cephalic version. This is a video on external cephalic version to turn that baby from breech to vertex or cephalic where the head is presenting first. I've actually never seen a version be successful, whether the patient had an epidural or not. And I think I realized when I was preparing this lecture for the first time and trying to find you guys a video, that the reason for that is in the United States, the providers typically do the version on their own, okay? What's really supposed to happen is two providers should be present, working together to push and pull the fetus in a specific motion to get that baby's head to turn to the downward position. It is very uncomfortable when they do it, so some providers will give an epidural first. If we get that baby to turn into the right position, they're going to put a binder on her belly, and then we're going to induce labor. Okay. If not, we're going to schedule a C-section because it wasn't successful. This is what it looks like. Hopefully you guys can hear it when I play. All right. It is uncomfortable if they don't have an epidural, for sure. Okay. We also are looking at fetal attitude. Fetal attitude doesn't mean that they're being rude. Fetal attitude is the relation. Sorry, I forgot to unmute, guys. What was the other question? Is it painful? Yes, it is painful. If they don't have an epidural, it can be very uncomfortable for the version. There's also a lot of risks with that. We could make the placenta abrupt from the uterine wall. We could rupture the amniotic sac while we're doing this. So there are risks when doing this procedure. So fetal attitude refers to not the fetus being rude, but the relationship of the fetal parts to one another. Okay, we want our baby to be in this flexion position, where the chin is tucked to the chest, and they're in that fetal position. Arms and legs tucked in as well. But chin tucked to chest allows for the presenting part, the back of the head, or occiput is what it's called, to present first, and it allows for that molding to occur very well so that the baby can fit through. Military position is where baby's top of their head is presenting first. That will mold, but not as well as the occiput or the back of the fetal head. This one here is brow position, where the eyebrows are presenting first. Again, the skull doesn't mold very well with the brows presenting first, and so it is a little bit more difficult. And finally, you have face presentation. Baby's neck is hyperextended, and they're presenting with their face first. These can all be born vaginally. It's just more difficult if it's not in that flexion position where the occiput or the back of the head is presenting first for that molding. These two at the bottom, if the brow or the face is presenting first, those babies usually will look like the Rocky movies, right? After they got beat up, right? Their face is going to be swollen and bruised, and then it'll start to heal. So we do like to warn our patients that they might have a little bruising with birth. Let's see. This is just talking about when the patient's head is presenting first. We want that presenting part to be the occiput, the back of the head, and just different words for different presentations. So brow or frontum is brow presenting first, face, mentum or chin. Don't worry too much about these words here. We're also deciding or determining which way the baby is facing in relation to mama. So we will be able to feel the sutures of the baby's skull, okay? They will have an anterior fontanelle, which is shaped like a diamond. Let me blow this up for you. Here, this is the anterior fontanelle that's shaped like a diamond, and the posterior fontanelle is shaped like a triangle. It's not a very good image here, but like a triangle. So we can tell just by feeling when we're checking the cervix during a vaginal exam which way the baby's facing. Typically, that occiput is presenting first, right? So we'll feel a triangle. The triangle points, when I'm feeling this, how I know which way the baby's facing, points toward the baby's face, okay? And so I know, hey, baby is facing toward mama's back, or baby's facing towards mama's front, okay? Really, when we're talking about the position, we're talking about where is the occiput, the back of the baby's head, in relationship to the mama. What I really want you to focus on this one is we want the baby to be facing in this OA position, occiput toward mom's anterior, which is her belly, which means that baby is facing facing toward mama's back, the face of it. We want them to be facing toward mama's back because when they get underneath that suprapubic bone, it's like crawling under a fence. They can get through it quicker, easier if they're on their bellies. So imagine yourself, if you're going to crawl underneath a fence, you're going to go on your belly so that your back can curve around that fence. Same thing when the baby's going underneath that suprapubic bone, we want them on their bellies so they can curve easier around that fence. Okay. If baby's occiput, back of the head, is toward mom's toward mom's back, posterior or back, that baby is facing straight up. So if you were to go under the fence or that suprapubic bone, it's harder to curve around that fence. Okay, so we would want them to be in the OA position, either straight up and down, just OA, or they could be tipped to mom's left, LOA, mom's left, or right, depending on where they are. But just remember, OA means that's our optimal position. Occiput anterior, baby's face down. If the occiput is posterior, facing toward mama's back, that's going to be a more difficult birth. It's still possible, just going to be harder to push that baby out. They also call this, if you guys have heard the term, sunny side up, where baby's face comes presenting up. And remember I said we're going to talk about those ischial spines. When we're doing a vaginal exam, typically we're going to do 3 measurements. We're going to check the cervix for dilation, how open it is. We're going to check the cervix for effacement, how thick it is. And we're going to also feel for those ischial spines and see how far in the pelvis the baby is in relation to those spines. Okay. If the baby's head is right at those spines, because we can feel those little lumps in there, if the baby's head is right at those spines, the baby is at 0 station. If the baby's head, and this is measured in centimeters as well, if the baby's head is above those spines, we're going to do a negative number according to however many centimeters above the spines that they are. Okay, so -1 would just be 1 centimeter above, -2, and so on. Okay, -4 is very difficult for me to reach with my short fingers. And then if the baby's head is lower than those ischial spines, then it becomes a positive number. Think it's positive to give birth vaginally, so positive numbers means the baby's head is lower than those spines and we're getting closer to delivery. Okay, we would start pushing around +1 or +2 station. Baby's nice and low. Typically mama will feel the urge to push here and can't control pushing, or if she has an epidural, she has lots of pressure in her rectum at this point. +3 station, we'll start to see the baby's head start to crown. +4 is fully crowned. Okay. Now that brings us to powers. Powers is the strength of the contractions. We're looking at not only how strong they are, but how far apart they are and how long they last. With every contraction, the placenta is being squeezed, and so it has reduced blood flow. So we don't want to have too many contractions, and we don't want to have the contractions be too long. Okay, yes, Marlena. That's okay. Mm-hmm. Above. Too high up. Mm-hmm. Yeah. Positive. Mm-hmm. Mm-hmm. Below the spines, and we're getting closer to birth. Correct? Mm-hmm. Okay, powers. We talked about measuring contractions in the electronic fetal monitoring video, which you need to watch before lab. It's in the lab module. But we're looking at a few things. We're looking at the duration of the contraction. That is how long the contraction lasts from the beginning of it, the start, to the end of it. Okay, how long is it lasting? And we're also looking at how far apart they are. So that's the frequency of the contractions. And we measure that from the beginning of one contraction to the beginning of the next contraction. So how far apart they are is frequency. We also are thinking about the strength of the contraction. We can get the strength of the contraction by asking a pain level. And if we don't have any internal monitors, we have an external contraction monitor. We can palpate during contractions to see how strong they feel. If a contraction is mild, the fundus of the uterus will feel like our nose. If you touch your nose, it feels like that squishy. Okay, that's a mild contraction. If it's moderate, it'll feel like your chin. And if it's a strong contraction, it'll feel like your forehead. It gets that firm. Okay. So that's how we would determine the strength of a contraction on the outside monitors with asking the patient how she feels. Sometimes the contraction monitor, when it's external, it will pick up a very small contraction, like it'll show that it's small, but the patient is in excruciating pain, or it'll show a very large contraction and they don't feel it at all. So we don't really know how strong it is unless we ask her on an external, what's your pain level? And then also palpate it with the contractions, feeling mild, moderate, and strong. Okay. Additionally, powers, once we reach 10 centimeters, we'll start pushing with the patient. And we only push with contractions because we want to use that force and mama's force together, making a nice, long, strong push. Okay. So we'll encourage her and let her know when the contraction starts building and encourage her to push with each contraction. Typically it's 3 times with pushing. So they'll take a big deep breath in and they'll either exhale their air while pushing and make noise, whatever they want to do, or they could hold their breath while pushing. We count to 10, try to get them to use a full 10 seconds push. Have them, and as they're pushing, baby's head starts to come down. Okay. Then they take a deep breath in and the baby's head sneaks up. So we tell them to take a quick breath and then push again. And each time they push, it's going to make a little bit more room and come down farther. Okay. So usually it's 3 times with each contraction and then have her rest in between. I think I saw a couple questions pop up here, so I'm going to pull this up. Will you see a delivery video? Absolutely. Here's your warning. You'll see a delivery video later on in the lecture. And yes, contractions hurt. As they get stronger, they become more uncomfortable. And as labor progresses, it becomes even more uncomfortable. So remember, powers is referring to uterine contractions and then also uterine contractions with patient pushing once they reach 10 centimeters dilated. What causes contractions to happen? It's a release of oxytocin in the brain, which binds to the uterus and it creates contractions. It makes the uterus contract and relax, okay? Sometimes if those contractions aren't strong enough and her labor has kind of stalled, she's not dilating anymore, we'll start a synthetic oxytocin, which is called Pitocin, or oxytocin. You might hear it used interchangeably via a very small drip. Okay, we started out at just 2 milliliters per hour and slowly increase it to get those contractions stronger and closer together. But we only do that if she hasn't been dilating like we would expect her to. Additionally, stimulating the nipples helps oxytocin release. So if we were to do, which I don't think we talked about in the last, specifically in the last slides about non-stress tests, we talked about non-stress tests, but we also have a contraction stress test. So what they would do for a contraction stress test is stimulate contractions or release of oxytocin by nipple stimulation. They could either pump or just stimulate the nipples, and it releases oxytocin and causes the contractions to start. Then we see how well the fetus tolerates those contractions to see if we could induce. If we thought this baby might be compromised somehow, we would do that contraction stress test before inducing labor. Breastfeeding also helps that release of oxytocin, which after birth will help with bleeding. This is what it looks like. Remember, the uterus is a muscle. True contractions will start at the top of the uterus and will get stronger and push the baby down and out. That's what causes more pressure on the cervix. And it begins to thin and dilate or open, which helps baby get pushed down and out. Braxton Hicks contractions are warm-up contractions, which happen anywhere in the uterus, not specifically at the top. And that doesn't put pressure on the cervix, so it shouldn't open. It's just the uterus trying to get strong, like working out, trying to get strong enough for labor. We also want to look at, when we're looking at the fetal monitor, how the contractions return. Does it return back to its baseline in between number? Because if it doesn't, that means that uterus is not fully relaxing and not fully reoxygenating the fetus in between. So we would be paying attention to make sure that they have that full relaxation in between. And the final P is psyche. How is mama dealing with that pain? It's super important that she's comfortable with everybody in her room. We as labor nurses need to establish a good relationship with her first, right off the bat. And then we continue care with her for our whole shift, or if she ends up in a C-section, we'll keep caring for her throughout that whole C-section. When a patient is in labor, especially for the first time, they become fearful, okay? This is called the fear, tension, pain cycle. They have fear of labor, which makes them tense their body up, which when you have tense muscles, it goes against what the uterus is trying to naturally do, right? So that could interfere with our goal of a vaginal birth. And tension, muscle tension, creates more pain. And so more pain creates more fear, which creates more tension, and so on. So we do different techniques to distract mama and break this fear, tension, pain cycle so that it not only pain will be reduced, but we have that optimal outcome of a vaginal birth. Different ways we could break that cycle is we could use distraction. We could have her bring in an ultrasound picture or show her an ultrasound picture of the baby on her phone. We could have pictures of their favorite vacation that they could look at or just imagine, talking through it with them. We could have them do aromatherapy. Different types of smells can help with pain and relaxation. We could dim the lights for her. We can play soothing music. anything to help distract her mind and breaking that cycle. Yeah. We're there monitoring mama and baby's status throughout the entire labor, and we're also providing labor support. A good labor nurse will be in that room the majority of the time trying to help her get in different positions, help her breathe, help her relax, and really support her. Now, there are some patients who hire doulas. Doulas are support people too, but they're paid and they're non-medical support, labor support. But they can come and help her support, but also that's our job too, is to help support her through labor, make her change positions frequently, and help coach her through this birth. No, that's the provider. If the provider makes it on time, most of the time they do, the provider will deliver the baby. If we are using a midwife, typically the midwife will begin with pushing and push with us in the room with the mama for as long as it takes. If it's a MD or a DO, an OBGYN delivering, they usually have us let them know when we start pushing. The nurse is then at the bedside coaching her through pushing. And for a first-time mom, that could take 2 to 3 hours on average. And then we call the provider, if they're an OBGYN, when the baby starts crowning. So it can take a lot of experience to determine, oh my gosh, what is that point where the provider will be here on time but doesn't have to wait around so long, because they don't like waiting, unfortunately. Yeah. Well, you have to check cervixes frequently. Yeah, but typically we don't deliver. We do have to know how to deliver in case a baby comes very quickly, but typically we don't deliver babies. Another question, let me see. Head is more like a basketball, is more like a football as it molds through. Yeah. And then it becomes nice and round after delivery. Is that what you meant, Donna? Feels like a basketball? Oh, yeah, okay. Gotcha. Okay. So, making sure that she's comfortable in her environment also means that when we're getting close to delivery, we're going to have the baby nurse, the nursery nurse, or whatever the facility calls that person, that's responsible for transition of the baby after birth. We'll have a labor nurse, a good facility. We'll have a labor nurse, and then one that focuses specifically on transitioning that newborn. So we usually, around 7 or 8 centimeters, will alert that nurse to come in and greet the patient so that there's not strangers in her delivery room. That would also interfere with our 4 Ps, right? And so they'll come in, greet the patient, educate what we would do, get her wishes. Do you want baby right to your chest? Do you want us to dry baby off first and bring baby right over to you? It's different for everybody what they prefer. Best place is right here, right away, so that they can transition together like we learned in the first lecture. The 4 Ps always work together to accomplish birth. If there's a disruption in any of those Ps, we could end up with a C-section. And so that's why we want to make sure all those Ps are working together for our optimal outcome of a vaginal birth. Which brings us to labor. What do you think starts labor, guys? What do you think happens in the body to make the labor start? A natural labor. Could be stressors. What else? Anybody have ideas? We're getting close to the due date, but what about those preterm labors? What's starting that? Maybe some hormones? Maybe about what's starting those contractions, right? And sometimes the water breaks and sometimes we have to break it. Could be release of oxytocin. It's actually a trick question, guys. Maybe it's growing too big, right? It's ready. But what if it's not? What if it's a preterm labor? Actually, a trick question for you guys. We honestly don't know what causes labor to start. We think it might be some maternal and fetal hormones mixing and creating the labor to start. If we knew, we would be able to stop all preterm labors, right? And so we really are not sure. Our theory is it's hormones. Yeah, sometimes people have what's called an incompetent cervix. It just dilates without even feeling contractions. So sometimes that happens, and they have to use a device called a cerclage to suture that cervix together. Yeah. Okay, so when we're getting close to labor starting, we get these signs called anticipatory signs of labor. They include GI disturbances, which is diarrhea. Diarrhea will happen when we're getting close to labor because the body naturally wants to clean out the bowel to make more room for the passageway, right? For the birth canal. And so they'll typically get diarrhea before labor starts. There is a thing called a mucus plug that covers the cervix, in between the cervix and the amniotic sac. And that mucus plug will start to expel as the cervix starts to open. And it is what it says it is. It's mucus. It's very thick and snot-like. And it's pretty big. And so when that mucus plug gets expelled, we know where the body is starting to get ready. Okay. It doesn't mean they're going into labor today. It just means the body is starting to get ready. And we have them let us know, especially if they're preterm, if that mucus plug comes out. That mucus plug helps protect the fetus from infection. But even if the water is not broken, that will also protect the fetus from infection. What was the question that I barely heard? Sure who it was. Okay, so we'll also get what's called lightening. Remember in that video in the first lecture, we talked about how the uterus grows all the way to the xiphoid process at 36 weeks, and then baby starts to drop down into the pelvis. That's lightening. So baby's starting to drop down in preparation for birth. When we have lightening, now mama can breathe easier because there's not as much pressure on her lungs, and she has to pee more because there's more pressure on her bladder. We already talked about Braxton Hicks contractions. Those are those warm-up contractions. That muscle is starting to get ready to be strong enough for labor. Most of the time, people will just feel tightening with these contractions. Sometimes they don't feel pain at all, but some mamas do feel pain, and so it just depends. They'll also get a burst of energy. This burst of energy is also called nesting, if you've heard of that term. That's where she gets really energized and starts getting the nursery ready, washing all the clothes, really preparing for the baby. And then as labor starts to get stronger, the cervix will start to ripen, which is soften. It'll start to thin or efface, and it'll start to dilate or open. As baby is moving through the birth canal during labor, it goes through these 7 cardinal movements. Now you might see more than 7. These are the only ones I want you to know, okay? When the baby gets into the pelvic inlet, that's called engagement. The head is engaged in the pelvis. As labor progresses, the baby will start to descend into the pelvis, so go down, move down through the pelvis. When the baby's head hits the pelvic floor, it will then tuck its chin to its chest in that flexion position. That's what we want, right? Because then the occiput, the back of the head, is going first. Someone is not muted. I'm going to try to find. So chin tucked chest. And then baby is going to do what's called internal rotation. So if they started sunny side up or occiput posterior, they're going to start to internally rotate toward mama's back because they know that they don't really know, but the body turns toward the mama's back so that they can start to move through the pelvis easier. Once the head is born, that's called extension. So baby comes underneath the suprapubic bone and they kind of look around. They're like, hey, I'm out, right? Not out all the way yet, but just their head. Extension coming underneath that suprapubic bone. Once the head is born, they turn their head back to align with their shoulders, which is called external rotation or restitution. Then the top shoulder will be born and the bottom shoulder then will come, and then finally expulsion where the full delivery of the fetus happens, so the birth. Birth time starts when the last part of the baby is birthed. So whether it's presenting head first, it would be once those feet are born, that's our birth time. Or if the baby's breech, once that head is born, that's our birth time. How do we know a birth time? We have our fetal monitor with us, and the labor nurse has their hand on the cords of the fetal monitor. If we're expecting the shoulder to get stuck, we're going to just pull out one cord once the head is birthed, and that starts the birth time of the head. In case the baby gets stuck for too long, so that we know exactly how long that head has been stuck for, or the shoulder has been stuck for. If we're not expecting that, we'll just pull both cords out at the same time. Anytime you pull a cord out of our monitors, it marks it on our fetal monitor for us, so we know the exact birth time when the baby is born. So we'll go back to that and refer to it later on. Queen is asking, why is it called spontaneous? Spontaneous means that it's happened without our assistance. So we didn't need to use a vacuum or forceps or do anything to help birth this baby. Okay. If we did have to help, it would be called assisted vaginal delivery. Okay. This is just a video showing it. It doesn't have any words in this video showing all of those cardinal movements. It does have some extra ones, but this way you can see what it actually looks like. Those, we call them cool dance moves as the baby moves through the birth canal. Okay. And so, when we are in lab on Friday and Saturday, you guys will get to see not the inside cardinal movements, but from extension, once that head is born, you'll see the internal or external rotation or restitution, and then expulsion. We're going to birth our mannequin at the end of lab on Friday and Saturday. Right, that brings us to stages and duration of labor. It has been about an hour, so let's take another 15-minute break. We'll start back at, what is that, 32? No, 37. Thank you. How to do math, right? Okay, so 37, we'll start back and finish up stages of labor. Absolutely. Mm-hmm. The foramen ovale. Mm-hmm. Yeah, sometimes. Uh-huh. No, yeah, totally. And that's when you would hear a heart murmur in an adult. Yep. Yeah, you're welcome. Y'all, I'll see you at 37.